Okay, everyone, if we could resume, if I could have everyone return to their chairs.
Can everybody please?
Executive Director Caroline Talib. OIDP staff, Sharonda Brown, you can return to the table. Alicia Diggs Extraordinaire, we can have you return to the table. You are. Our doctors are leading the way and mentoring for us. Okay, we're going to go ahead and get started. We do have the next segment of our agenda this afternoon being led, if you will, or facilitated by Dr. Sullivan and Tukes, but we will actually hear directly from the Office of HIV Prevention and Care at the Alabama Department of Health, and we also will hear from some folks within the Division of Infectious Disease for the Center for AIDS Research here at the University of Alabama in Birmingham. So we do have some important updates to hear for our next segment. Thank you to everyone who returned on time. So I will get us started by turning the floor over to our two leaders on PACHA. Dr. Tukes and Sullivan, take it away.
Thank you. And thanks everyone for being back. And we're going to introduce our speakers, and then we'll have some time for discussion at the end of the session. So I think we had a great start in our introductory session, hearing from Dr. Harris about some of the data around the epidemic in Alabama. And I was reminded of one of my mentors who was at CDC in the early days of the HIV response, who talked about, Dr. Jim Curran, who talked about public health data as the conscience of the epidemic, that when we look objectively at the data, it forces us to have some of the hard conversations about who in our communities are impacted, which parts of the state, which of our fellow citizens are impacted by this epidemic. And so today we have two Alabama voices who are going to help us to look at and to understand some of these data. And to get things started, I'll turn things over to Dr. Tukes.
Thank you, Dr. Sullivan. I can't understate the significance of this visit to Alabama. Thank you for welcoming us to your state. It has been heavier than I expected, and heavier than perhaps all of us can handle. But the visit to Selma, the visit that we've had in Montgomery to the Legacy Museum, and I had the chance to go to the Memorial for Peace and Justice today, it has been truly life-changing. The rural poverty that we saw on the road to Selma, the potential lack of power, lack of plumbing, lack of hope, it was really hard to take in. But I was optimistic about a lot of the work that was going on with Black women here in Alabama. But I didn't hear as much as I would like to hear, and hopefully I will, from you, Von Treese, about Black MSM, about migrants, about people who use drugs, and about the trans and gender expansive communities, because we know that they all play a major part in this movement for health justice. So with that said, I'm going to introduce Von Treese McGee. She is Director of the Office of HIV Prevention and Care at the Alabama Department of Public Health. She is an 18-year public health veteran with extensive experience in HIV prevention and care. And Von Treese, welcome to PACHA.
Thank you. Thank you everyone for being here. I was pleased to get the invite from PACHA to be a part of the panel, so thank you all. As he stated, I'm with the Office of HIV Prevention and Care.
with public health.
Can we start the slides? Yep.
The mission of the Office of HIV Prevention and Care is to improve the quality of life for all Alabamians by ending intersecting epidemics impacting HIV and hepatitis C through equitable, accessible, and stigma-free prevention and treatment services. Our office vision is an Alabama that embraces the dignity and self-respect and universal caring in the human experience where HIV and hepatitis C is eliminated by leveraging community partnerships. As we know, the South is the epicenter of the HIV epidemic in the US. The South is disproportionately impacted by HIV, with the highest number of people living with HIV and the highest number of HIV new diagnoses. In 2022, more than half of new diagnoses in the US occurred in the South, despite the region only representing 38% of the US population. In 2022 in Alabama, there were a total of 779 newly diagnosed cases, with the majority of those being among Black non-Hispanics, males, ages 20 to 29. And in 2022, there was an increase in the risk, transmission risk as heterosexual contact. And Jefferson County showed the highest number of new diagnosis cases. Over time, there has been a small drop in the number of new diagnoses. The data for 2020 should be interpreted with caution due to the COVID pandemic. Sex at birth. This slide shows the data for 2014 and 2022, and it shows an increase in males from 72% to right at 78%. However, there was a decrease among females from 28% to 22%. Race and ethnicity. Black non-Hispanics is our largest race group that among new diagnosed cases, followed by white non-Hispanics, and then Hispanics and multi-race are very similar in diagnosis. Again, the 2020 data, as throughout the slide, you'll show those numbers being interpreted with caution. For new diagnoses, age reflects age at the time of diagnosis. Those under the age of 13 is not reflected in the graphic due to them representing less than 1% of those cases. The highest proportion of new cases has been among ages 20 to 29, followed by 30 to 39, 40 to 49, and then 50 plus. 13 to 19-year-olds make up the lowest proportion. Transmission risk. Historically, it has been MSM, but in 2022, the reported cases was, the highest reported cases was heterosexual contact. But there was also a large number of undetermined transmission risk. And that's due to the risk ascertainment delays. MSM is the highest number, then followed by IDU, MSM, IDU, and then perinatal exposure. Prevalence in Alabama, we currently have 15,576 people living in Alabama as of December 31st, 2022, with the majority of those cases being Black, non-Hispanic, male, the sex at birth as male. Reported MSM as a risk factor and live in Jefferson County. And the difference between the prevalence and the new diagnoses is age, and that is mainly due to the improvements in effectiveness of HIV medications, where people are being diagnosed early and staying in care and being able to live longer and healthier lives. These numbers in terms of prevalence have grown since 2014. And the reasons that people tend to drop out of care, and not drop out of care, but drop out of those numbers is due to them dying or moving out of Alabama. Again, there's a comparison between 2014 and 2022 in terms of sex at birth, with the percentage of males being the highest, and then there's also an increase during that time. As stated before, age, the biggest notable difference in age is the 50+ age group due to those living longer. So that is the highest rate of HIV cases in Alabama. Transmission risk is MSM. That's the same as throughout, nationwide. Those numbers in Alabama does reflect those of the nation as well. In Alabama, this is our 6 highest counties with the highest cases, with Jefferson County being number 1, Mobile, then Montgomery County, Madison County, which is in northern Alabama, Tuscaloosa, and then Houston County. So we're ending the epidemic. Alabama was one of the 7 states that were awarded funding due to its substantial rural burden. Dr. Harris did point out earlier that 55 of our 67 counties are rural, outside of the state's major and minor urban populations, with 40 of those counties being considered extremely rural, and only 7 counties are in major urban centers and 5 are in minor urban centers. So with our program with the Department of Public Health, we do receive Ryan White Part B funding. However, there are organizations in Alabama that receive additional funding. So parts B, C, and D are funded throughout Alabama outside of the Department of Public Health. Within our department, those services highlighted in blue are Ryan White Part B, are Ryan White services that are funded through our organization. And one of the things with Ryan White funding nationally, there are about 90.6% of clients receiving HIV medical care through the Ryan White program that were virally suppressed, compared to 69.5% in 2010. The Alabama Department of Public Health also receives funding for ADAP, which is the Drug Assistance Program through the Ryan White program. And what we do with our ADAP program, we fund eligible clients to receive medical and dental care, medications, and insurance premiums, medication, and co-payments being paid for as well. And the eligibility for those clients, they have to be living in Alabama, HIV positive, have a gross income exceeding 400% of the FPL, and be ineligible for third-party payers, meaning that we're the payer of last resort. So some of the factors driving the HIV in Alabama is social stigma and fear of disclosure. Stigma is an enormous barrier to fighting HIV in the South. The fear of being judged and discriminated against due to their HIV status can prevent people from disclosing their diagnoses and seeking treatment. Economic constraints, where the cost of medications, transportation to appointments, and potential loss of income due to illness would deter people from seeking treatment. Our rural communities will have higher levels of poverty and HIV-related stigma. However, the Department of Public Health remains vigilant in supporting and promoting best practices that help reduce stigma and increase access to prevention and care services and other health resources. Limited access to healthcare providers, particularly in rural areas, can hinder adherence. Mental health issues such as depression, anxiety, and substance use can interfere with the ability to manage medication schedules and attend appointments. And lack of understanding or support from family and friends can also make it difficult to adhere to treatment plans. So this is just a number of ways that we here are addressing the epidemic in Alabama. Identifying and re-engaging people who are previously diagnosed but not in care. Through the Department of Public Health, we have a HIV re-engagement program where we employ social workers that engage clients that have fallen out of care from 1 to 10 years to identify ways to get them back in care and to link them back into care with one of our providers. Improve early diagnosis of HIV infection. We continue efforts with the local health departments, CBOs, ASOs, and other partners to make testing simple, accessible, and routine. Implement Rapid Start Initiative, linking people to care and treatment within 7 days is one of our EHE goals. Increasing PrEP usage of people at high risk for infection. And increasing partnership with rural CBOs and healthcare providers. Our rural communities have limited access to healthcare services, and healthcare providers may have limited experience with HIV and be less likely to provide testing or PrEP. Increasing partnership in rural areas will help us to close the gaps in HIV prevention and care in those areas. So this is a list of some of the emerging activities that we are implementing through our department and along with our funded partnerships. Testing initiatives in correctional facilities, including reentry facilities. What we're currently doing is partnering with the STD division along with the ASOs throughout the state to conduct testing throughout the state prison system. We're working with the Department of Corrections to develop and implement a re-engagement plan for people with HIV being released from the DOC system to assist them with linkage to care, including ART and case management services. Again, Rapid Start being part of our EHE initiative, the goal is to link those diagnosed with HIV to treatment within 7 days. Our patient navigation program. This is a program that we'll be implementing in early 2025. And our patient navigators will be culturally responsive champions who facilitate patient engagement with care and treatment services. And the purpose of this intervention is supporting people with HIV in assessing care and treatment services and remaining engaged in those services. The intervention plan is initially for a period of 90 days, but can extend up to 180 days based upon the need of the client. Provider PrEP awareness and education. Routine opt-out testing. The UAB currently implements routine opt-out testing at its emergency department. And so one of our goals is to expand and implement routine opt-out testing in emergency departments and other healthcare settings in our high prevalence communities. ADPH is also partnering with the AETC to provide awareness and education on PrEP to healthcare providers. We're currently doing a behavior scan for an environmental scan on our behavioral health services being offered throughout the state in order to refined a behavioral health service enhancement model. And visioning days. Visioning days is scheduled meetings that we have with internal and external partners to reflect on past accomplishments, identify priorities, and plan for future activities. And this is a list of our funded organizations, but it's not inclusive of those that are not funded. And we have a number of those as well. But these are the organizations that provide our prevention and treatment services throughout the state. We also work with traditional and non-traditional providers. And the goal is leveraging resources and expertise unique to individual CBOs and ASOs to end the HIV epidemic.
Thank you so much. It was a great overview of the epidemic in the state, and I think we'll ask people to save their questions about that presentation, and we'll do all of them at the end. But thank you for setting the stage for us, and we're going to next hear from Dr. Letitia Elapre, who is an associate professor in the Division of HIV/AIDS at UAB Birmingham. She's also the clinical core director of the UAB Center for AIDS Research. She earned her MD at the University of Florida College of Medicine, did a residency in internal medicine and an ID fellowship at UAB, and along the way somewhere also earned her Master's of Science in Public Health. And she currently is a practicing physician and also engaged in a program of research, particularly around improving HIV prevention among vulnerable populations facing high levels of stigma, which is something we'll want to talk more about. But please welcome Dr. Elapre, who's going to talk about multi-level determinants of HIV in Alabama.
Thank you so much. Thank you for having me on the panel, and thank you, Montrese, for providing all this information in regards to what the epidemic looks like in the state of Alabama. And I just really want to expound upon that and talk about some of the drivers of the epidemic, what really is causing us to have such disproportionate rates of HIV among Black communities, and especially among our LGBTQ+ communities. So I'm doing this from a perspective, really looking at what the root cause of all of this is and trying to understand it at multiple levels. And so I will try to share some of that with you and be happy to answer questions regarding it as well. So I wanted to just highlight the fact that racism has deeply impacted the HIV epidemic in our state. We talked a little bit about the prevalence of HIV and where the rates are the highest, but what I really wanted to highlight with this slide is that this is along the Black Belt. And I remember when I wrote my first grant, someone said, you have to explain what the Black Belt is. People don't know what that is. So the Black Belt is where you have Black soil. It was rich and fertile, and it's where cotton grew. And that is where slaves were historically most concentrated. And that is still where Black populations and communities are the most populated, especially in the South. And so just this graphic alone is showing you the impact of racism historically and currently on HIV rates within our state. We also are a state of immense poverty. I don't think it's clear, even from driving through the state, to understand how much poverty really impacts our rural communities and how that impacts their ability to live and thrive, and also impact their likelihood of being diagnosed with HIV. In regards to Medicaid coverage, we have some of the worst, unfortunately. We are a non-Medicaid expanded state. We are ranked 49th in regards to our ability to provide coverage for our population. And if you think about who actually qualifies for Medicaid, right now for a family, essentially they have to make about $4,700 in a year to be able to access Medicaid within our state. That is less than what it costs to pay for an HIV regimen. We are also a state that has really, I think, unfortunately, implemented some very restrictive and oppressive legislation. And I think we fear that this may be a growing trend nationally. So we are a state that implemented SB 129. The impact of that right now is still to be seen and to come. But what I fear is that it's going to be a result in which my child is no longer going to be able to learn about the history of our state and be proud of being Black in America. We have HB 314. We do not allow any abortion access. I think people don't always realize this also means that providers cannot educate and tell people where to access abortion services. And if they do, they can be charged with a Class A felony. So they go to prison. And then we also have, unfortunately, restricted and prohibited the ability for our trans youth to access gender affirmation care and services. So all of these policies and laws are going to impact the HIV epidemic and health overall for the most marginalized populations within our state. And then I want to close with highlighting the idea of community intersectionality in the individuals most likely to be diagnosed. So when I was a fellow until my time now, I really wanted to talk and elevate the voices of people impacted by the epidemic. In our state, the population most likely to be diagnosed is someone who's Black. And for these men who identified as gay, bisexual, and queer. And we talked to them. We said, what is your lived experience? What do you think are the drivers of HIV? What prevents access? And we talked to about 45 men, half of whom were newly diagnosed with HIV. And unfortunately, they said that no one really talked to them about what it meant to have risk. We failed as public health stewards. I failed as a provider to really educate that really just the prevalence and local likelihood of you contacting and being intimate with somebody who has HIV, because the number of people around you are more likely to be diagnosed is the biggest driver. And most of them said, I only had sex with one person. I was in a loving relationship and no one said that I could get HIV. We talked a lot about stigma, and I want to point out just the idea of intersectionality. So to be Black, gay, and live in the South is a very difficult position to be in, especially to be accepted amongst your community as well. So a lot of the conversations focus around religiosity and feeling like HIV is a punishment to gay people from God. Another individual said, I don't feel like I've ever had true peace of mind in a sexual encounter in my life. And that was related to the fact that he had to walk in the South as a Black gay man. They felt like their sexuality was an affront to what was idealized as masculinity, which made it harder for them to accept and love themselves. And they specifically talked about that within the Black community with which they lived. And they said that within the Black community, foundationally, I think it's conceptualization of masculinity is no longer congruent with what it means to be gay in the South. And then overall, I think we've already talked about this, but they specifically honed in on the lack of discussion around sexual health within Black communities. And they said that they felt like their white gay counterparts didn't have to live with the same silence and the same stigma that they lived with. I think it was what most profound is that the real hurt that you could hear in their voices, feeling like they were not really being accepted and loved for who they were. And so I'll just add, I focused in on the Black community and specifically Black, gay, bisexual, and queer men. And we asked them, who do you feel like potentially could help with acceptance? And they identified Black women. We moved our research to say, okay, identify Black women. You want to talk to them. You want to understand how they support you. And there was some beauty in what they said. They talked about emotional support, really being able to attain social capital, especially if they were newly diagnosed with HIV. But there was also a lot of homophobia. And this was expressed by the Black women that we interviewed who were their main support anchors. And I point this out because I really want to drive home how much homophobia impacts and affects the epidemic in the South. And so one woman said, I am scared for him to be around my grandson, that's 10. And another person said that, unfortunately, they don't want it to be what is considered normal and to be male. And so we were devastated reading this, but I think mostly when we went back to our cab that was full of Black gay men that identified these women, we had to talk to them and walk them through the trauma they experienced, knowing that even amongst the women that they identified, they weren't truly accepted in what they felt like loved. So I just wanted to I'm sorry, not end on a bad note, but end on a note that really discusses and I think highlights why we have the disparities that we have in Alabama and what it means for our ASO partners and for our state to really end the HIV epidemic locally. So thank you.
I'll just reiterate the thanks for our speakers, and I think it's such a powerful way to head into this conversation because Vontrice has shared with us sort of the objective pieces of the epidemic, and we should get into some of those and talk about them and how they're typical of the South, and if there are things that we have questions about. Letitia, I think you've gone a little bit like vertical in some of these about what some of the underlying drivers are. And I think these two pieces always have to exist together, and we always need to understand the stories, and we need the public health surveillance efforts to understand that they are our GPS to figure out whether we're even heading in the right direction and give us that signal. So I just want to thank both of you for what you bring to this conversation, and I think that gives us a way to talk about either side of this, which is, you know, what stands out from the epi data that you saw? Was anything unexpected? What questions do we ask about that to sort of get at better prevention and care? And then how do we link up addressing these underlying causes and the challenges of that, which both of you, I think, have alluded to because a lot of this has to do with where you live and where the state stance is on some of the kinds of services and the setting in which we all live, love, and seek to take care of ourselves. So thank you for that great opening.
I just want to add, you have not failed as a public health official. You have done incredible work against insurmountable odds. You have not failed. You are fighting a righteous fight, and I want you to remember that every single day.
Thank you. Thank you.
So if we have questions, tense up. Oh, there they go. All right. Excellent. I have questions too, but I will prioritize my friends on PACHA, starting with our fearless leader, Marlene McNeese.
Sure, I'll try to be brief, but thank you, Dr. Ellapre and Vontrice. Particularly Vontrice, you know, and I know how hard it is for, as a representation of the government, to implement a lot of these services in our political context. And I really just want to say, it is impressive that you have spent so much time in your seat. The other part of the challenge we have is not having leadership who look like us remain in seats that are operating and managing and making decisions around these program approaches. So I just wanted to put that out there in the universe. But really, we've seen so much success in the Ryan White program, and I know that is a big part of your portfolio, and that we now know that when we enroll successfully folks into that program, they can achieve viral suppression. We're making an A grade with that approach, but we still have more than 200,000 individuals who are not enrolled. They are living with HIV and not in care. States like yours and mine who have chosen not to expand Medicaid have done some unusual things. I won't call them tricks, but they've done some things that try to resemble an expansion or an improved access to healthcare. My question probably is more to you, Dr. Ellapre, on whether or not it's working. What I know in Alabama is that there has been a specific policy change, if you will, that I think may be onto something. I'm curious to know, is it working? But extending Medicaid support for women 12 months postpartum, post-pregnancy. And if approaches in states that refuse to expand Medicaid, what are some real practical, tangible program and policy steps that we can help push forward in light of that? You know, nothing replaces expansion. Nothing does. I mean, there are traumatic benefits when we do, but in states like ours, there's 10 of us. around the country who sit stuck, the things that they have been able to do, is it working for you all here in Alabama? Just a quick question about that.
So I don't believe that it is. I've been excited that there has been some movement in regards to also trying to expand the level of poverty someone has to live in if they want to receive cancer treatment as well, if they're on Medicaid. But no. So if you are trying to get reproductive services through Medicaid right now, the amount of coverage you have is extremely limited. If you are a male trying to receive services just for reproductive purposes on Medicaid, the only thing it covers is a vasectomy. It is extremely limited to be able to offer meaningful care that is actually going to have health outcomes that are optimal if you have someone coming in the door who's uninsured or underinsured because they're somewhere in a gap, because they're not quite poor enough to get Medicaid, and they haven't been able to really, I think, benefit from any type of real insurance coverage. So I don't think so. I think we really do have to expand Medicaid. We have to have more universal healthcare coverage, where we look at healthcare as a right and everyone has a right to receive insurance. And that's the only way that we're going to see improvement, I think.
Amen. Tori Cooper.
Thank you, ladies. Thank you very much. This one was a little tough. It was tough because the data was tough. I believe that I saw on one of your slides, Vondrese, that there were about 7% of new diagnoses in 2022 were transgender folks. Yes. It was a tiny little sliver of yellow.
No,
No?
I didn't, there was no transgender numbers on that slide.
So I thank you for saying that. All right. So with that being said, we know that transgender folks in Alabama, even if you don't know specific numbers, you know that they're being severely impacted, and trans folks make up between 1% and 2% of the general population. So how is it that in Alabama that you all are prioritizing what we would deem as priority populations, the folks who are the most impacted by HIV, even if they don't represent the largest numbers? And sometimes they do. What are some innovative ways? This is hard. What are some innovative ways that you are doing that, ensuring that the people who need it the most are getting what they need? And I wrote down one example. I think about the Ryan White program. And as a transgender woman, I can't imagine having to access housing in Atlanta. Where are we?
Alabama.
In Montgomery.
In Montgomery.
When there are places where I can't even use a bathroom.
Mm-hmm. So for us with our funding, transgender people are one of our priority populations. So when our providers receive that funding, that is one of the populations that they have to identify how they're going to reach those populations. And it does vary between the different organizations, but we do have organizations such as AIDS Alabama, Five Horizons, and others that that do provide services and do prioritize those populations. And I'm just drawing a blank in terms of specific programming, but I'm aware that those organizations who are represented here today do serve those clients and do make that a priority population.
I'll just add that from a clinical standpoint, we try to make sure that we partner with organizations that are primarily made of transgender women and for transgender women. So one of the main ones is TAKE. They help us in regards to being able to offer housing when we aren't able to offer housing in a meaningful way. I've also been, I feel privileged because there's a gender affirmation clinic within UAB that I'm able to refer my patients to. One of the most devastating things I think I've had to experience is people coming in, and because they make too much money be able to access services like Project Access if they're undocumented, not being able to go and get real care and gender affirmation care. And so I've been proud that our clinic has still prioritized and said we need to make sure that people feel comfortable and love themselves and live with themselves in a way that's meaningful. And they have used Ryan White funding to make sure that we can offer gender affirmation care within our clinic. So I think that there are innovative ways you can get around states that have legislation that is hateful towards a specific population. You just have to have leadership that cares.
And I will add, in terms of our funding, we have not had an organization that responded to the RFPs. And there could be a number of reasons for that. But I know with some of our organizations, they will not write for the federal funding because of the restrictions or the requirements that come along with it. So we are looking at ways to identify how to get funding to the communities through possibly our lead agency, which we partner with the United Way of Central Alabama. So in terms of being able to do the reporting, the fiscal aspects of it, that could be challenging for some of the organizations.
Marvell Terry II.
Thank you. All my life, I have been told that I am a risk as a Black gay man growing up in the South. And so in your explanation of your data, you had a question that said, what is a risk? And I hope that we get to a place in public health where my body is not a risk, or that my pleasure, or that my intimacy is not a risk. I think there are things that make me I think there are things that make me vulnerable to HIV, but I hope that we can, even in our national strategies, we can look at Black folks as whole people that deserve pleasure and intimacy, and what we do it's not risky, it makes us vulnerable, but I would suggest that we will be more willing to be honest if we're not told that what we're doing is risky. That I wouldn't have to sneak and be more honest with my provider if what I'm told is not risky, but it makes me more vulnerable. So I hope that in all of our work as we leave here, that we reframe this word risky and put it in an approach of vulnerable, because Black folks get to have pleasure and we get to enjoy intimacy.
I completely agree with you. That's the reason why I put that slide up there, because I do think that we focus too much on risk and the idea of what puts somebody at risk. Where I think we failed is really telling people that it's not about how many partners you have, what type of sex you have. You need to have pleasurable, honest, awesome sex. But that really, when we're talking about HIV diagnosis and living in the South and being Black in the South, that alone makes you more likely to be diagnosed. That's it. It has nothing to do with us as individuals. So I completely agree with you, and I thank you for your comment.
Dr. Moore.
Thank you. So first, I just, want to commend the both of you because I recognize the amount of work that you're doing in this state. I'm from Mobile. Although I live in Los Angeles, I'm from Mobile. And I know the challenges there and throughout the state. I have a few questions first for Vontrice. So I wanted to know if there's any data regarding PrEP use here in Alabama that is being regularly collected or that you could share about. You also mentioned that trans data wasn't included in the slide. So I'm just wondering how the Alabama Department of Health gets a sense of the percent of trans people living with HIV in this state. And then a third question was regarding direct patient care. And I was wondering, does ADAP provide direct patient care? Does the Alabama Department of Public Health provide that? And then one more question.
He's having to write a list.
My fourth question is regarding social stigma, because, I heard you mention social stigma and, I recognize we're in the Bible Belt. you know, and there's a lot of stigma. I was wondering, are there any campaigns that ADAP is doing, you know, just to even raise awareness about HIV, how it's transmitted, even if it doesn't particularly go into the level of different like specific groups, but providing that education at that state level across the state. Because one thing that Dr. Ella Prey mentioned was a lot of the Black gay men that you spoke with saying they wish they knew, they wish they had information about even how HIV is being transmitted and things of that nature. Thank you.
So I'll start with the media campaign. We have been conducting media campaigns throughout the state in terms of advertising PrEP, U equals U. We've done them in bars, nightclubs, gas station, pump, those areas, just throughout the state, billboards. So we do advertise the PrEP initiative, U equals U initiative, and knowing your status. And with that, we direct them to the local health departments because there are 67 counties, so we do have health departments in each county. So that's what we're doing. We do run into issues in terms of media because we are the health department in Alabama. So there are things that we would love to do that we are unable to do. So we are limited in that area as far as some of the information that we get out, but we do make sure we get out PrEP testing, knowing your status, and U equals U. In terms of direct patient care, the Department of Public Health does not treat positive clients. We do testing, and what we do is we link them to care. When they're linked to those providers, the providers do the assessments in terms of seeing if they qualify for our ADAP program, which is our drug and medication, and our insurance program. And of course, there were those requirements. So we partner with the organizations that actually do the treatment throughout the state. PrEP usage, I do not have those numbers, but that information is available and I can do a follow-up and provide that. And as well as transgender, the way we focus on that is because that's a national priority, but in terms of specific percentages, I do not have that, but I can also do a follow-up with that as well.
Last but not least, Carol.
Thank you both for some really insightful and candid presentations. I want to just touch for a second on some of the incidence and prevalence data. And we all know the limits of incidence and prevalence is those who were tested. So you really don't know who isn't tested, right? And one of the things I've read about is how Alabama and some of the other southern states have seen a surge in Latino Hispanic population, and in particular undocumented. And so I'm wondering, with that very low, and I'm sorry, I don't remember if it was prevalence or incidence, but that very low number in Latino and Hispanic, what are your thoughts about those that aren't tested, and you know, where does that factor into programs and outreach? Or is it really just that low?
I don't think it's that low. There's actually, I want to just highlight before I start that our aid service organizations and Ryan White clinics are amazing. So in regards to the prior question, they have a community of practice Alabama Quality Management Group. They also have ASONA, where they share data on the HIV care continuum and the PrEP care continuum, and they also share best practices. So just shout out, they're awesome. And then in regards to our Latino population, I would say that the current push to do like ICE at every door, massive deportation, like that was very strong in Alabama, probably about 10 years ago. I feel like our Latino population lives in silence, and our undocumented populations live in silence. So the likelihood of those data being accurate is probably low.
I'm going to turn it over to Patrick, but I have to say, Dr. Elopre, I'm so happy that there is academic freedom and that you can speak so freely. This is why we have to
Probably gonna get in trouble.
preserve these institutions. No, as an academic, I value you, and I am so thankful that you've been able to share these insights with us. Dr. Sullivan?
I have like a piece of information to add, and then I'll just try and summarize a little bit and thank our speakers. Andres, I think many health departments, as Alabama, don't themselves collect data about PrEP because it can be provided in so many clinical settings. It's challenging. There are a couple central resources that can produce data at the state level. And so the CDC has some of this, although they've taken some of it down for technical reasons for a period of time. AIDSView has state and county level estimates also. And but I think what this highlights is some things that we might think of as inherently governmental, maybe in other areas of health and wellness that we feel like we'd like for government to be resourced to do. And sometimes it's left to us to piece together, where that information lives. But just more broadly, I want to really reflect on what both of you brought here today. And I think we hear this in the context of having done the visits of I think people having really profound and intense feelings about being in Alabama, about learning more about the history, about seeing some of the places that we've heard about in terms of the civil rights history. And so I think your presentations really are situated for us and like being like having seen some of those things and in the context of being in the state. I think that the partnership here and what's been highlighted about the role of some federal programs that are administered through states and the role of states in collecting through statutory authority, data about the epidemic, and in partnership with academic institutions, which may have some different kinds of freedom, to provide services. And I think this is the two of you have really laid out, and I think your presentations show that partnership, but I think this exists to some extent in every state where there needs to be this collaboration between what the state can inherently do and what other kinds of organizations, community-based organizations and academic organizations bring alongside that. And then I just want to also acknowledge that the other thing that this brings forward is that often in the governmental side of public health, which I've sort of lived in both of these houses, but also in academic public health, sometimes we use words that are really like epidemiology terms, but that have important meanings for community. And so Marvel, I really appreciate you calling out specifically our use of the word risk as a epidemiologic construct that we then bring into the space of talking about how people live their lives and the things that all of us do that act to improve our health or to make us vulnerable to some health conditions. So I think it's also just an opportunity to reflect on how we choose the words that we choose. But in the end, for me, however we think about this, I think there's a resilience in the efforts of state health departments. Again, there's a lot of variability in state legislatures and state government, but there is a core federal contribution and resource here that gives us a common denominator. And so I really want to appreciate, Montrese, you and your colleagues who work not just in the state health department, but in providing these services and generating these data. And I think Alabama is an especially good example of bringing together the strengths of government and the strengths of academia to ask questions that the other may not be able to, but then having a conversation together about how this comes together to improve health. So with all that, thank you both for what you've brought. Thanks to our PACHA members who shared questions. And thanks in terms of the planning of this for making space for a conversation about public health, academic medicine, and a picture of the epidemic in this state. Thanks.
We have really kicked off this meeting and went deep just immediately. So I appreciate everybody for bringing and sharing what you have. We will not take a break. We will move right on. Our next update, if you will come from another one of our very own PACHA members and co-chair of our subcommittee for the global work and the global effort. So Dr. Jen Cates will walk us through some important global updates.
Good afternoon, everyone. We've come to the last segment of a very intense day, and couple days, I should say. So we just have to take a deep breath, all of us. I am not providing a global update today. That's going to be tomorrow. I am facilitating an important wrap-up session that we wanted to ensure we had an opportunity to have, which is, we already heard a little bit earlier from Admiral Levine and from Francisco, some of the amazing policy steps that the administration and the different agencies have been taking. But we really wanted to provide an opportunity for PACHA to get a fuller summary of all of those ways that our incredible leaders at HHS have been knitting together policy and regulatory change to move forward on a whole range of areas that are directly related to HIV, as well as the environment in which people with HIV and those at risk live and work. And all of these together, I think, we as PACHA should be able to understand the full range of those things, what's been accomplished, what's still outstanding as we go forward. PACHA is going to be here. And we're going to be doing the work. And so we have to have this opportunity to have that list. And what I'm hoping is that with all of the smart people in this room, you'll be thinking and asking questions about what we're going to hear. So I'm very, very pleased that we have two people with us that made time in their very busy schedules to come here to Alabama and share this with us. We will, and I think you know them. We're going to hear today from Adrian Shanker, who's the Deputy Assistant Secretary for Health Policy at the Office of the Assistant Secretary for Health at HHS, and also Brian Kaplan, who is the Senior Advisor to the Chief of Staff in the immediate office of the Secretary at HHS. And they both agreed, and they had crazy schedules, so we had to kind of figure out a way to make it work for them to be here. It's not, I mean, you're doing a lot, as you said, there's a lot to wrap up right now. To give us this overview. And then we'll have some time for our questions to them. And I would just urge everyone to ask those questions in mind for the work ahead. So I will turn it over first to Adrian. Thank you.
Thanks, Jen, and thanks to Kay and Carolyn and all of PACHA for not only being here in Alabama, but for making time to hear about some administration updates. Both Brian and I have had the absolute honor and pleasure of serving in this administration. And the Biden-Harris administration has made an incredible commitment to advancing health equity, including equity for people living with and at risk for HIV. So what we wanted to do right now is to kind of go through in a little bit more granular detail than what you've heard earlier from Admiral Levine in terms of kind of the full breadth of what this has looked like at HHS. We're going to highlight 4 different areas. So prevention, quality of life, stigma, and science. And I'll start with some items around prevention. And I should just say that this isn't 100% comprehensive because we have a small amount of time, but this is a good focal point. So on the PrEP side, we've done enormous work to advance access to PrEP in this administration, including finalizing a landmark national coverage determination for Medicare participants. In fact, it's the first national coverage determination to include multiple modalities. First national coverage determination on any topic to cover multiple modalities. Our PrEP NCD includes all forms of PrEP, including all future FDA approved versions of PrEP. So that could include future oral or injectable PrEPs. Thanks. There's going to be a lot of wins here, so we're not. But the NCD makes PrEP free for everyone on Medicare with no cost sharing, no copays, and no deductibles. And that went into effect in September September 30th. We also, through a separate action, made PrEP free in the next plan year. So for most Americans, that begins January 1st, but it's whatever their next plan year is, for anyone with private payers. So again, PrEP free, private payers in the next plan year. That's finalized. We've proposed a PrEP risk adjustment for insurers that will help to motivate better PrEP coverage for, again, mostly for private payers that are not, well, there's some differences in the types of payers, but basically the ones that aren't already being required to make it free, there's now some additional incentives, including marketing incentives for the insurance companies to really promote access to PrEP. We've proposed, and with great gratitude to Captain Neblett Fanfare, CDC has proposed new CDC screening guidelines for HIV that the proposal removes the upper age limit that's currently in the HIV screening guidelines. And by the way, PACHA asked for that when you passed a resolution asking for it. So thank you for advising the department. CDC also piloted a really groundbreaking at-home HIV testing program, and all the indications that have come back from that program have shown that it didn't duplicate services. In fact, it reached an entirely different group of people that were not accessing HIV testing. Through our SOGI Data Action Plan, Sexual Orientation, Gender Identity Data Action Plan, CDC also made changes to the case reports used for HIV, most STIs, and MPOX to add sexual orientation in addition to the mode of transmission, meaning MSM or injectable drug use does not tell you if a person is gay or bisexual or heterosexual, right? So, that has been put into place. On the syphilis side, because we want to frame this as a syndemic, Admiral Levine mentioned the syphilis task force, which she has chaired, and both Kay and I have had the chance to witness a masterclass in her leadership of this really interagency task force. But through that task force, CDC finalized DoxyPEP clinical guidelines that are really critical to helping to address the syphilis challenges that we face. And HHS implemented this through 4 different divisions within our department, making DoxyPEP free for anyone on, DoxyPEP free for anyone receiving care through Indian Health Service, Ryan White program, SAMHSA's harm reduction programs, or Title X family planning clinics. We also published through OASH, the Assistant Secretary for Health, we published point of care syphilis testing to help advise providers on when to use the rapid syphilis test versus the confirmatory test. We've really tried to focus our syphilis work on really education for knowing when and where to use what thing to resolve the problem that exists in front of us. And we have started to see results. I'm going to pass it to Brian for the next part here.
Thank you so much. And truly just a testament to a lot of the work he's done across the department. My name is Brian. I'm a senior advisor in the Secretary's office, excuse me. And this is actually my first PACHA meeting and possibly my last, since we're leaving quite soon. But it's been an honor to share the space and this important work with all of you. I'm also here to give some greetings on behalf of the Secretary. He is really supportive of this work and the commission members here. So thank you all for everything that you do. The next bucket that I'm going to talk about is the quality of life bucket. And particularly, we think about that as work that enhances support and protections for people living with HIV. First, I hope to talk about 3 critical and interlocking civil rights rules that were promulgated by this administration through our Office for Civil Rights, and that's 1557, the Provider Conscience Rule, and Section 504 of the Rehabilitation Act. First, of course, the big one is implementation of 1557, which has gone back and forth for about a decade now, and ensures equal access to healthcare and prevents discrimination, including on the basis of sexual orientation and gender identity. Unfortunately, at the moment, this rule is enjoined in the courts, and we hope for timely resolution of that litigation so that this important rule can go into effect. In the meantime, we've worked to finalize other rules that are not currently tied up in litigation. And again, these rules are interlocking, so some of those protections do overlap. And in particular, we'll continue to protect people living with HIV in their access to care. Our Office for Civil Rights updated the Provider Conscience Rule, which strikes a balance between statutory religious freedom protections for providers and also access to care for patients. So this rule updates policies around the civil rights complaint process, making it easier for folks, and makes it clear that healthcare providers, if they choose to deny care, must provide clear notice and also assist with access to alternative sources ensuring that patients receive uninterrupted access to care, for example, for their PrEP or HIV treatment. The third rule is the first update to Section 504 disability protections in over 40 years. This rule now provides presumptive discrimination protections for all people living with HIV for federal disability law, regardless of any extenuating factors, which is a major step forward in health equity. And we really hope all three rules will continue to lay the groundwork for civil rights protections for people living with HIV. The other major item in the quality of life bucket that we heard a little bit about earlier that I really want to lift up is the new Ryan White HIV/AIDS program policy that allows program funds to support security deposits, which really reflects our understanding of the critical role that stable housing plays in successful HIV treatment outcomes. As you all likely know, Ryan White for the first time announced that its clients had hit over 90% in viral suppression, well above the national average, which is amazing. And this is really a testament to the program's ongoing work and creative solution finding, including this policy to really assist with rental security deposits. And now back over to Adrian for bucket 3.
The next area is our work to address HIV stigma, and some of the stigma work interlocks with like other types of stigma because stigma doesn't exist in a vacuum. So the United States Public Health Service, of which we have a couple of our wonderful officers here today. The United States Public Health Service is one of the United States 8 uniformed services, and we have approximately 6,000 officers serving, many at HHS, but also actually across other departments. The United States Public Health Service became the first United States uniformed service to end its medical exclusion of people living with HIV, as well as people living with hepatitis B. That was a really significant action. Admiral Levine herself is very proud to be the head of the Public Health Service and to have directly led that policy shift, which we also think just updates the way people think about HIV broadly. So yes, it is absolutely critical for the readiness of our Commission Corps, and also it challenges stigma around what it means to be ready to serve, right? The second area that I want to highlight is our effort to really change drastically our blood donation rules in this country. So the FDA's policy, their guidance to the industry on blood donation, which came out earlier in this administration, shifted from a time-based deferral, most recently 3 months, but as many of you know, it was, went from lifetime to 1 year to 3 months, which all felt arbitrary to the community. FDA had different reasons for these timelines, but to the community, they all felt very arbitrary. We changed that to an individual risk assessment where all blood donors of any gender, of any sexual orientation, any gender identity, they're all asked the same questions. So rather than being told you can't donate because of your sexual orientation, which is largely because of presumptions around HIV, now everyone's asked the same question. We know that this is not a perfect solution. It's based on the science that exists today. The FDA continues to do work on new types of science to figure out how to address issues around PrEP, for example. But based on where we are today, this is a significant improvement and a significant change in how people are both able to access blood donation. We've seen, for example, college campuses resume blood donation drives. So that's good broadly for the health of our nation, but also we're seeing people feeling less discriminated against and less stigmatized when they seek to donate blood.
Perfect. And then the final category we wanted to talk about is advancing science, in particular driving innovation in clinical trials for prevention, for treatment, and quality of life to end the HIV epidemic. First, you heard from Admiral Levine that several weeks ago, we were proud to finalize a rule implementing the HIV Organ Policy Equity Act, or the HOPE Act, allowing for the first time for HIV-positive kidneys and livers to be transplanted to HIV-positive recipients, free of any research oversight or existing administrative barriers. This is a huge step in advancing both research and patient care, as the data on kidneys and livers were exceedingly strong in all the studies that were done to date. And critically, the final rule was also published in tandem with NIH proposed guidelines for HOPE Act research. And actually the public comment for that closes tomorrow. If adopted, this is an opportunity to further expand to other organs for transplantation beyond kidneys and livers, really build that evidence base and continue to build on health equity for the community. Next, talking about long-acting PrEP, which we've heard a little bit about. The administration has done a lot to encourage research into long-acting PrEP. As everyone knows, FDA approved the first long-acting PrEP as safe and effective earlier in this administration after significant federal investment, and NIH trials on the 6-month injectable are ongoing and favorable. As Adrian mentioned, there's been a lot of work on the coverage side, that national coverage determination and the switch from Medicare Part D to Part B coverage of PrEP, which really will allow for coverage of provider-administered injections for the first time. And finally, on clinical trial diversity, I'm hoping to discuss just a little bit about what that commitment has looked like from HHS and the Office of the Secretary in particular. We all know that HIV trials in the past have been historically uninclusive, including PrEP trials, which has limited who can benefit from these life-saving medications. The Secretary has been strongly interested in clinical trial diversity since his time in Congress and has really called on NIH and industry to do everything they can to address this with some pretty substantial results. We made a lot of progress here, and we really hope we can continue building on clinical trial diversity. So do you want to? Sure. There's a little bit more to talk about here, but we've done some really important work across the continuum of prevention, stigma, treatment, advancing science, and improving quality of life. The Biden administration has really led the way on transformative accomplishments in these areas that we hope will be built on for years to come. Adrian got a directive from Admiral Levine, and I got one from Secretary Becerra to go as far as we could on HIV policy and bring the full might of the department to that work with incredible partners at HHS, at the White House, and with key stakeholders. As Secretary Becerra often says to his team, don't do mild, and we are called on these positions to do everything that we can and to make the most change that we can while we have them. And as today's presentations from all day make clear, there is just so much more work to be done, and we hope to keep partnering with you all. So thank you. Sorry.
And to kind of follow on Brian's closing there, you know, Brian and I start and end almost every single day together and are usually connecting 3 to 4 other times at least. This policy portfolio has been a huge priority for all of HHS, and that's why a lot of policy has moved forward. But I want to make it clear that while this administration is incredibly proud of its work on HIV and the broader syndemic, HIV is a nonpartisan issue, and it's not controversial, and it shouldn't be. And so with the pride of the results from this administration, we also, you know, just want to say really boldly that whoever wants to work to help to end the HIV epidemic, to support the quality of life of people living with HIV is, you know, they are the right partners to work with. And so my strong hope, and I think the strong hope of the administration, is that this work really continues and doesn't lose steam. As Paul mentioned earlier, things are within reach. And so we're proud to have gotten closer to within reach, and there is more to go. And you know, hopefully a lot of this work is able to continue. So we're happy to take some questions as well.
Great, let's first clap. Yeah, it's incredible to hear it all in one place. I have 3 quick comments, but then I'm going to open it up to our questions. It's one of the things that I hear across all of these are really about structural change. So that's something that we at PACHA have talked about a lot, that making structural change is really what will have impact in people's lives. Second, we often in the past have pointed out places where HIV has led the way, that in many innovative pathways that have helped other diseases, have helped other populations. And one, I just wanted to highlight the NCD determination and having the multiple modalities. That could stand to help lots of other conditions over time, and we should remember that. And then finally, this is a personal thing. The 504 provision was where I sort of cut my teeth on policy. I was a freshman in college and was on a task force. This is 40 years ago to look at 504 and try to implement it in a college setting. And it was the first time I got exposed to the role that policy plays in people's lives. And so to hear this now is just so exciting to me personally. So with all of that, I see we have some cards up. Jeff, I saw yours first.
Yeah, thank you for highlighting the role of clinical trials diversity in research. Wondering if you could maybe expand on that a little more, especially the need for, there's a lot of talk about having certain percentages and so forth, but I think what's most important, and depending on the size of the trial, is if it's statistically significant, it could show a verifiable difference between the various groups, and not just ethnicity and genders, but also age. And then secondly, where the rubber really meets the road, as we learned with the Descovy debacle, as the FDA not just issuing guidances and recommendations, but actually enforcing, not allowing drugs that don't have that kind of representation in the trials to get approved. So any comments on that would be appreciated. Thank you.
Absolutely, and that's something that I was kind of obliquely referring to as Descovy and some of that history. There has just been this strong push for both FDA and NIH to really look at all of these criteria and make sure that they're looking at the whole picture of what a study looks like and kind of engaging at the front end and every step of the way to make sure that those are all met. There's also a lot of work in Congress, actually, and this is something the Secretary was involved in when he was in Congress, to figure out what the barriers are, particularly for low-income patients, Medicaid patients. For example, can Medicaid pay for clinical trial participation, pay for additional resource that way? So there's ongoing work to see kind of what is possible, but just erasing those barriers and doing everything we can with those companies and NIH and stuff is something we're working on. Anything else?
Great. Marlene, I have you next.
I have a global question. No, I'm just kidding.
I'm sorry, you're going to have to wait till tomorrow.
No, I just wanted to thank you, Brian and Adrian, for sharing those important milestones in the work. And somehow we do need to tell our stories better, and having something summarized that really speaks to all of the aggressive systemic change work that has happened, that can be the guide map, if you will, for future administration. So I do hope that we are able to receive something by way of summary, just being able to share these important things so that in community, on the ground, that individuals are able to share and educate their own local jurisdictions and constituents about these important federal changes. And then there are two places where I just want to put it back on your policy radar for however long you get to continue the work. But the idea that we have real challenges with CMS's lack of enforcement around really covering appropriate and most effective medication for people living with HIV. I sit in a state with an insurer who shall remain nameless at the time, who still refuses to cover single tablet regimens for people living with HIV. That's still a challenge and still something that I think systemically this administration could do something about, or certainly putting that on the to-do list for the next. And then, quite frankly, I just wanted to know if you have heard recently, I heard of a publication that talked about SOGI data collection in the country, and that it's kind of horrible in the way that we don't have consistency on the way people define their SOGI metrics. So it's better than we were, but certainly not ideal where I think all of us wanted to go when we first started talking about having better awareness around the people that are being served in these federal programs. So just wanted to put that out there. Don't know if you have any comment around SOGI data, et cetera, and where we go from here, but just wanted to raise those two issues.
Yeah. So first, we are here for approximately 30-ish more days. So just Brad and I we have a hard stop date. On the question about CMS, I would just say that that timeline does not work for broader, we did not get to every single thing we wanted to get to. We got to many, many, many things. And in terms of this list, we can share it with the OIDP team after we just check internally and make sure. But everything we've stated today is already a matter of public record. We wanted to consolidate it for you, so you kind of had it all in one place. So we will find a way to make sure we get that to Kay and Carolyn, and they can share it. And then in terms of SOGI data, so the president signed a bold executive order a couple years ago that called for every department and agency in the federal government to create a SOGI data action plan. HHS's plan is forward-thinking and ambitious, and it required every HHS division to do a comprehensive review of their data instruments and actually make a plan for implementing SOGI measures. We have done, frankly, an enormous work on SOGI data that does include standardization, although standardization is complicated because different data systems require different types of questions, and different survey respondents, like for example, youth or older adults, require sometimes some nuance there. So it would probably be a deeper offline conversation that I'm happy to have with you, but I can say that within HHS, we do have a lot of standardization. The challenge that you're referring to is the difference between state data and either private sector or federal data and either private sector data or state level data, where they don't always align with the federal, with the ways that the federal government asks questions. And we're very restricted in how we can ask the questions. Yeah.
Great. So we have two more questions and we'll have Shannon and then Duvia, and then we're going to call it.
If you want, maybe they can ask together and then we can.
Yep. Why don't we do that? Both of you can ask your questions and then we'll have them.
Great.
Okay.
So mine is a three-part question, but on the same topic. So all prep related. Number one, I know at one point the Indian Health Services was not offering long-acting injectables. Has that changed? That's number one. Number two, you talked about cost sharing being removed for PrEP. Does that include long-acting injectables for the commercial plans specifically? And then number three, one of the things that we learned in COVID is that when the federal government offers 100% federal match, it's a lot easier for states to implement things in their Medicaid programs. And that does require congressional action. Has there ever been a discussion, or are people open for the conversation around PrEP coverage in Medicaid with a higher federal match in order to entice states to up their game?
Okay, can we get?
So mine is also a PrEP question. So I want to just acknowledge like all the work that you've done to get PrEP access. The site visits and engagement visits that we've had, we continue to hear that a big challenge is not to access is these prior authorizations. So what advice do you have in working with the new, administration moving forward on policy to remove some of those barriers related to prior authorizations?
I'm happy to start. And then, okay, so on Indian Health Service currently does not offer long-acting injectable PrEP. I don't believe anyone from IHS is here today. So Kay and Carolyn can help PACHA members connect with folks at Indian Health Service if you'd like to, have a deeper conversation there. Yeah, in terms of the PrEP NCD, the National Coverage Determination, that does include all forms of PrEP, including future forms of PrEP. So that does include both all currently approved oral and injectable PrEPs, as well as future forms of both. So yes, no cost sharing, no deductible, no copays for Medicare participants for injectable PrEP. That also, by the way, includes all wraparound services. So it includes lab work, it includes a certain number of STI tests, it increases the number of HIV tests for Medicare from once a year to 7. It covers those wraparound needs, and the effort to do this was to ensure that it actually met the need, right? So you mean for the private payers? I don't want to misspeak, but I believe that it does include all forms of PrEP. Is that your?
It does. This is for the individual markets, so like healthcare.gov plans. It does include all forms of PrEP and no cost sharing, including for the ancillary services that Adrian mentioned. The problem is enforcement. And so we see that plans haven't consistently enforced that. There was a letter that was put out by departments of HHS, Labor, and Treasury basically saying, no, we're serious. And then some follow-up work to really make sure that plans stick to that. And there's a bunch of news articles with kind of like secret shoppers. So a lot of work to kind of show that there's really a gap here and continued oversight is needed. But that's really what the problem is there.
I think that we can really recognize that, we've done a lot, but there is some stuff we didn't get to. And so the prior authorization piece is an example of, I do think that some of these actions on PrEP access will cause a significant shift with prior authorizations, but because they haven't all gone into effect yet, I think that more time will be needed to know what additional policies are needed in the future. Like once this new policy is in place in the new plan year, then we'll have a better sense. Unfortunately, like Brian and I won't be there to work on it, but you all can, right? Yeah.
Well, thank you so much. Please join me in thanking Brian and Adrian. And I'll turn it back to Marlene.
So I want to thank Jen and just remind everyone to follow your lead when she asked that we all take a deep breath. It has been an incredible engagement so far. I do want to thank everyone who came out today. It's been extremely informative and impactful and emotional. We will resume tomorrow, so I'm looking forward to the continued discussion and learning opportunities. For those that came to join us in the room, I do invite you to come back and join us for day 2. We also have opportunity where we get to dialogue and have real conversation with you in our PACHA-to-the-People. It's why we come outside of Washington, D.C. in the first place. It's so that we can get an opportunity to talk with you. So that will happen again on tomorrow. Just wanted to say thank you to Defina yet again for all that she has done. I heard song and singing. That is amazing. And so I want to thank Carolyn Talib and all of the team at OIDP. They worked tirelessly. I mean, months and months of work and detailed conversation to make this look seamless. It's not at all. They put in many hours to make that happen. And of course, to Rose Lee and to all of our support teams at HIV.gov who keep our conversation going out to the public and to the people. Just a reminder, we begin tomorrow at 8:30 a.m. We will have a very full agenda and we are trying to adjourn at 3:30 for many of us have flights. So if we can come on time, we can certainly stick to our timed agenda and adjourn on time. So tonight we recess and I will see you all in the morning. Thank you.
Produced by the U.S. Department of Health and Human Services.